Good morning, everyone, and thank you for joining us for this second session of our Grand Round series at Global Neuroscience Institute. It is my distinct pleasure to introduce today's guest speaker, Dr. Salah Aoun. Dr. Aoun is an assistant professor of neurosurgery at UT Southwestern Medical Center. He specializes in minimally invasive and complex reconstructive spine surgery. I've known Dr. Aoun for the best part of 2 decades now, actually more than 2 decades now. We were both fellows studying cerebrovascular and skull-based diseases until somehow he got called by the dark side and moved into spine. So he completed his residency at UT Southwestern in neurosurgery, did a fellowship there as well in complex spine, where he joined as a faculty in 2020. He is a prolific researcher and writer. He has authored more than 90 peer-reviewed papers, in addition to book chapters, editorials, lectures. I, for one, cannot wait to hear this talk to understand why he abandoned cerebrovascular diseases. But in all seriousness, we are all very excited to have you today to talk to us about 3D modeling in its use in spine surgery. The floor is yours. Oh, before I forget as well, just for everybody, please throughout the talk, you can ask your questions through the Q&A button, not the chat button. It'll make it easier for us to go through all your questions at the end.
Thank you, Dr. Rami. I really appreciate it. We will bring you over to the dark side, with time. I really appreciate the invitation to talk and give grand rounds. I'm going to talk about something I'm passionate about, which is improving outcome through spine surgery and technology. I do a lot of reconstructive work. It's the bulk of my practice, but I also do minimally invasive surgery to avoid bulky deconstructive work. And I'm going to talk about how technology and 3D printing has made my life easier and I believe improved outcome and minimized reoperations. These are my disclosures. When we talk about 3D printing, this is what people usually think about. They either think about a resin-based 3D printer where the model comes out where you manage to make small figures, usually under 10 inches, or about an extrusion system where you have a single extruder or double extruders building the model from the base up. And that is, for the most part, true, but it's become much more involved and complicated. The material used for 3D printer are extremely variable. These are a few samples. It can go from PLA, which is the most commonly used, polylactic acid, very easy to use, very easy to manufacture, but has a very low durability, so it's usually an indoor material for tabletop models. ABS can be used industrially. Nylon, material infused like wood infused filaments can also be used industrially, and it goes on to the point where you have either dissolvable filaments that can, let's say, dissolve in water or dissolve in oil based on the application need. You can also have filaments that are food compatible. And each one of these filaments have their own characteristics, both in how you manufacture them as far as printing temperature and machine temperature, and as far as their ductile and strength capabilities. And that kind of funnels in the application and the breadth of use for each one. So when people think about 3D printing, usually it's like, okay, it's some of the school application, maybe a little bit of engineering, mostly small models, but this has changed radically over the last 5 years to the point where we have entire buildings now that are being 3D printed, both because it's easier as far as construction, it's faster, and it's much cheaper. And this is a live, a true picture of a hospital in North Africa that was built only with 3D printing, where they go ahead, make the foundation, the building, the walls, and the ceiling, the roof, all 3D printed with a massive industrial 3D printer, and then they add on the interiors and the windows, and this can be constructed in record time. But what really has propelled that technology forward is the adoption by the military. So the U.S. Army especially has realized fairly early on that it's much safer and cheaper to manufacture parts locally at the front line rather than have them shipped over. And that's when we saw this technological explosion with use of metal for 3D printing or more complex material. And we've been using 3D printing in medicine for a while. Dr. Rami and I have had this vascular model probably 14 years ago when we were still doing research. And these models were purely educational. Same for the spine model, where the spine, I think it's designed by Emery, was buried in sand to allow residents to work on putting pedicle screws. The application and learning from these models is limited because it's a static model that allows you to extrapolate what you're going to do to everyone else through them, but it's fairly limited. And recently, we've seen that advance quite a bit, whether it's with stock implants like this banana T-lift gauge that's 3D printed both in a honeycomb fashion and micro etched at the same time to look like bone, and in custom implants like this femur prosthesis to replace the actual femur patient after cancer surgery, or just a study from China where they actually reconstructed the dents in part of C2 in a child when they were trying to spare the joints. Currently in spine surgery, there's three major aspects of 3D printing. I use it, and our institution uses it for deformity correction. It allows us to plan the osteotomies better, the derotation maneuvers in a big coronal curve, allows us to think about how we're going to place our instrumentation, especially if patients have aberrant anatomy. That'll allow to line up the screws better with the correction in mind so that the routing doesn't take long. We also use it for patients with aberrant anatomy when we want to do something very minimalistic. Patients with supernumerary vertebrae, abnormal TP anatomy, and we look at a few cases. We can use that both for the tube placement and to make sure that we have the entire target of resection resected at the end, because you can get lost in anatomy fairly quickly. Another important part is teaching, and that can be patient teaching to make them understand the scope of their procedure in clinic. So if it's a big deformity surgery that needs to be planned ahead, we usually have time to actually deep print the patient's own spine, show it to them in clinic. That does a couple things. One, they understand how bad their deformity is, because it's hard to understand that unless you've felt the model and seen it live. Two, it makes them much more compliant with the restrictions we give them after surgery, because they understand what kind of work is needed to make them better. So they're more compliant with their physical therapy, more compliant with the restrictions of limitation, and much more compliant with the brace that we ask them to wear. Also, it's very important for our fellow and resident medical student teaching, because it's much easier to learn something once you have your hands on it instead of having the abstract model in mind, like most of us have learned the craft that we use. This is one of the 3D printers that we use. It's made by Raise 3D. They make industrial printers. It's a dual extruder printer, meaning it can print two materials at the same time, and I'll let you know why this is important. This printer is capable of printing an entire spine. So it'll print it from C2 all the way to the actual pelvis. So it makes it much more practical than reassembling a model from smaller parts. The printing of a full spine, even with the best printers currently, can take up to 3 days and needs some degree of supervision. So this is not something you just leave at work and come back to the next day unless you want to come back to a potential disaster or fire. We have these printers at home so that there's always someone that has eyes on them, and they have an integrated camera and a fire exhaust system as well in case something happens. The two material that we use is for a reason. The orange material is actual the model. The white material is dissolvable filament. And the reason why I'm showing this is that if you guys want to print a spine, that's a very important part of it. Spines in general have a lot of overhang. So if you want to print it without printing errors that are frequent, you're going to need support to basically bolster these horizontal segments so they can lay on something. The beauty of using this PVA material is that once you're done, you just put the model in water as is, and overnight the white stuff dissolves. So you're left with the actual model that looks like this. So when we initially started the 3D printing experiment, we started just with normal anatomy. And the anatomy I thought was most compelling to me was the C1, C2 rings. One, because it's a complex joint. Two, because most people are worried about putting hardware at C1, C2 because of the nerve root, the spinal cord, and the vertebral artery. So it allows us to teach residents and to learn, the ease of placing screws there. And I can tell you, it made me a much more efficient surgeon once we started doing that. It helps us also teach residents and students the importance of that pivot and how dislocation or distraction of that pivot can compromise the canal, as you see on the right. The next step was to start printing that for our trauma models. And these were life-size. They're easy to do because the cervical spine is relatively small. This is one of the first models we did for a hangman's fracture, just to showcase to the patient how a hangman's fracture looks like and to residents as well. So once we started doing this at a bigger scale, we published it for our scoliosis, and this was published in Operative Nerve Surgery a couple years back. I'm going to start showing cases, and I'm happy to take questions at the end about these cases. So this is one of the first patients we did. He was a 62-year-old man at our county hospital. He had a bad MVC, motor vehicle collision accident, and had a fracture dislocation of his thoracolumbar junction, as you can see there, that was left untreated. Miraculously, he was not injured from a neurological standpoint. And this is a patient that pretty much everyone at County Hospital know, because he used to walk bent in half, carrying his bicycle on and off the bus that has a stop right in front of the hospital. But he was fairly unhappy. He's relatively young compared to our spine age of, the average for our spine patients around 72 to 75. He was walking stooped, and he came to us when he couldn't take it anymore because his pelvis started engaging under his ribs. As you can see here on the left side, this is when patients really become miserable. It's when their ribs lie on their pelvis. It hurts the ribs and it also compresses the stomach, so they stop eating because of reflux and they start losing weight. And usually that's the start of a very dangerous decline. So we actually 3D printed their spine. That's some of the 3D modeling we did before actually printing the spine. But at that time, we were only doing tabletop models. So we ended up having this tabletop model. And you have to remember, this model looks better than the patient standing because any 3D printing we do is based off of them laying down in the scanner. So the fact that this model is better than his x-rays when he stood up shows that the gravity has a big component of making him worse. And these are the patients who do really well, even if you don't correct them completely. And that allowed us to really study how we're going to put our construct, how we're going to correct him, both in the coronal and the lateral plane. He was extremely happy afterwards. And a year later, he left I think he left to go to Atlanta. He was getting married. So that was a good result. I think the 3D printing helped us really plan our screw placement, our auxiliary rods in a way that made that surgery more efficient, at least saved us some time in the OR because you already know what you're doing. And it allowed the patient to know how bad he was. So he was extremely compliant afterwards. As a goodbye present, we actually printed his screws and gave that to him, and that, just as a goodbye. This is the second case. So this is a slightly more complex case. He's a 64-year-old man with musculoskeletal scoliosis. He had Parkinson's disease. These patients become scoliotic because the muscle tone is so high, it distorts their spine anatomy, and they're notoriously hard to fix without balancing them really perfectly at the end of the procedure. You cannot be left with anything that looks like a kyphus because they're going to contract over it and have hardware complications. So he resisted surgery for a long time until he had an epidural injection for radicular pain right at the apex of his spine. He was unfortunate enough to get an abscess from that, which led him to having a spinal cord compression there, and then a laminectomy there. The laminectomy made him much worse because you took out the posterior tension band and made him kyph forward more. So he came to us fairly miserable. And if you look here, the pelvis is also engaged under his rib. And he came to us after losing 20 pounds in the span of maybe a couple months. So this time we printed his pelvis as a whole and as a life-size model because he also had 6 lumbar vertebrae. So now you have a patient with neuromuscular scoliosis, abnormal anatomy with 6 lumbar vertebrae, a prior laminectomy. So a model like that would have been very useful. He had also abnormal sacrum at the top, so the sacral foramina were irregular. So if you're putting S2A1 pelvic bolt screws, it's important to localize these foramina, and you can lose a lot of time, even with navigation, if you don't have an idea where you're going. And this is a picture of him in the OR. You can see the model is life size. It kind of reflects his scoliosis there. And this is after our dissection work. We're pleased to see that even the laminectomy side matched with the model. And this is after we're done. The planning that this allows us to do is, you plan where your dual head screws are, where your connectors are, and you plan how many bolts you put in and where. And he was extremely happy when we were done. We have a very decent correction. Despite all that, he was fly fishing at 3 months, and we have to have a discussion about that and how we should do that fresh after surgery. But overall, I think the reason why we had a swift and efficient surgery was because we were well prepared. If anything, printing the model and looking at it beforehand forces you to really know what you're doing in the OR before the case. So after doing this for complex spine, we're like, well, we wonder if we can do this to avoid spine fusions for patients. So this is a case report we published recently. So this is a very pleasant 40-year-old woman. She was a school teacher, and she started having a side joint pain 6 months, a year after her second child. Her pain was present for 10 years, but then it became intractable after her second delivery. And she had Bertotti syndrome that was complex, meaning she had 6 lumbar vertebrae. And for those who don't know what Bertotti syndrome is, it's when the transverse processes of the most bottom vertebra, be it L5 or L6, articulates with your sacrum, meaning instead of these TPs being free floating when you move, it starts rubbing the wrong way on the sacrum. And when patients get to 30 years old or more, and when arthritic changes aren't as tolerated, this is when that pain can become pretty bad. It's like having bone pain from loose hardware. It's very typical to that. So typically for this, you fuse the patient. You either give them 2 level A lifts if they have 6 vertebrae, or you do a posterior lateral fusion. But that condemns them, if they're that young, to adjacent segment disease. So you pretty much condemn them to having more surgery later in their life, plus the back pain that comes with giving someone fusion. We were wondering if there was a way to just get rid of that articulation in a way that's efficient. And that patient had a very complex Bertotti joint. You can see how the joint on the right side is flat but very large. On the left side, it's more complex. And you can also see the erosive changes on the sacrum and the SI joint due to that constant rubbing. So we 3D printed that model. And it was really nice to see that articulation both in the coronal plane and on the lateral plane. And you can see how she has that happening on both sides. She has a few sesamoid bones too. That's a sign of chronic friction there. And we showed that to the patient, just to explain to her what was happening. So that allowed us with the model in the room to just drop a tube on each side and basically remove that joint. You can see how that joint is very apparent inside the tube on the AP. And this is a pre and post. So pre, you can see how part of the TP is there. Post, you can see how we pretty much took out most of that TP and gave her a lot of clearance so that once she moves, she's not going to have residual friction from that stub of the TP we lift. And we actually printed that post, and you can see how we have clearance now compared to before between the transverse process and the sacral aorta. She was very happy after that was done, and I think having the model in the room really helped us be confident with the degree of her resection. Otherwise, surgeons tend to stop when they feel like it's becoming risky. This was very deep into her back, so without the model, we probably would have stopped earlier and maybe left more for residual. And the next step was we started thinking, how can we combine 3D printing to customized patient hardware, because now you're becoming more and more specialized as far as how you treat these patients. And these are all my cases, so if you have questions, I'm happy to answer. This is a 44-year-old man who came to us from Mexico with severe Sherman's kyphosis. So he had congenitally wedged vertebrae at the apex of his thoracic spine. And he had borne this his whole life, but he came to us when the spinal cord draping over the spinal column became severe enough that he had myelopathic symptoms. So he started having the feeling of ataxia. He was wobbling when he was walking, and anytime he put his foot on the floor, he had a triphasic clonus. So he was pretty much jumping around while walking, which is not, compatible with being functional. He even tried bariatric surgery and lost about 100 pounds without improvement, and that's when he came to us. And if you look at his CT scan, this is a true Sherman's kyphosis, meaning he's got solid bony bridging both anteriorly and posteriorly on the spine. Now, that's important when we consider surgery for these patients. It means that we can't just do Ponti osteotomies. We can't just remove the joints at multiple segments and fold them back. They just will not fold. You need to take a wedge off the bone and do a pedicle subtraction osteotomy to make them better. And we 3D printed his spine. This is the 3D rendering of it. And then we used a company that's a subsidiary of Medtronic, which is one of the companies that we use here, that will help us plan our osteotomies, meaning we tell them, hey, these are the patient characteristics. He's got a pelvic lumbar mismatch, so his PILL index is -21, should be around 5. He's got very exaggerated thoracic kyphosis that should be around 30 to 40. We plan on doing an osteotomy that's going to gain us, and we told them probably 30 degrees. Can you tell us how he's going to look later? And can you custom make rods for us that are going to tell us in the OR if we have achieved our goal? Meaning, we tell them we want a rod that's going to reflect a pedicle subtraction osteotomy of 30 degrees. Can you make one that's going to predict that? And they do. And that's extremely important because you can use that rod as a template in the surgery. Because in surgery, we don't have Scully x-rays, we just have the C-arm x-ray. So it's a very localized shot. It's hard for you to know if you've accomplished your goal. But if you have a rod template that will not sit on the patient correctly unless you've done the job, that's very useful. So that's what we did. And this is the preoperative plan prediction with pretty much how much we would expect to see as far as changes. So we wanted to get his PIL closer and his thoracic kyphosis closer to normal. And this is how it actually looks post-op. So this is the pre-op image. This is his planning with the rod. And this is his post-op image. And we got actually better correction after surgery than we had initially planned. And they'll actually follow these patients with us for life. So every time we have a clinic visit, they'll recompute them. This is post-operative image. You can see the pedicle subtraction osteotomy and the pizza wedge with folding of the vertebra over. And that's the planned result afterwards. That looks more like an anatomical spine should look like. And this is nice. So every clinic visit, they'll basically compute the values and add that to the patient. So we actually got a -10, a better improvement on PILL, and a normal thoracic kyphosis. This is a patient that was extremely happy after surgery. I'm going to show this case as the last case, just so we can do with coronal deformity now. This is a lady that's the other end of the spectrum. She's someone that we really wanted to save a long segment fusion going to T4 because she already had a C2 to T2 fusion. And if you fuse them to T4, you only leave 2 segments between the screws. That's a recipe for disaster. So that means that now you're compelled to link up her hardware to the cervical hardware. It's a very morbid, debilitating way to be fused. So we asked them if they could compute that alignment for us to see if we can do it to T4, and they did. So she was 65. She came with us with extremely rapid weight loss. Her bone quality was good, but she lost a lot of her muscular mass. You can see that she's cachectic there. She was unable to eat. Her BMI dropped from 26 to 19. And you can see how her pelvis is inside her ribcage here, which explains why she's having so much problem with keeping food down. And this is what the actual patient gets. So that's the unit rotting. That's pre with post, and the patient gets that. They get the rod and the specification that they've had to manufacture that rod, and this is the post-operative result. We're able to leave several segments between the two constructs, and hopefully that'll buy her some time until she has a breakdown that needs to be fused more completely. To be fair, this probably just delays that. I don't think in any way it safe keeps patients from having the big surgery, but if it buys her 10 or 12 years before that happens, that's a lot of young functional life that we're able to give her with good planning. I know I rushed through it a little bit, but I'm happy to take any kind of questions, any comments.
Thank you for this tour de force of cases. These are, you know, for people who don't do a lot of spine, these are the cases that typically other neurosurgeons run away from. So I'm glad that actually they found you. But
they run away toward us, unfortunately.
yeah, these these are. If I'll start with some questions if or anybody else has questions. But actually, I answered one of my questions. I wanted to see if you use the models that you create. If you actually on the actual model, do you ever do the surgery on the model to see how much degree of correction, or is it more electronically on the iCAD that you use it first?
So we do it electronically just because of the expense. So these models are very cheap to manufacture. This entire spine model, once you buy the equipment machine, is like $20. And the scope of how much they're going to pay for their surgery and how much healthcare is covering, it's very low cost. If we were to add screws to that, you're adding about $50,000 to $60,000 of cost. The only time we use these models for screw placement is in addition to our cadaveric models. So what we typically do, we'll have a cadaver lab for residents with 2 or 3 cadavers, and we have hardware brought in for the cadavers anyway, and we'll bring in 1 or 2 prior cases like that model we printed out, and the residents try to plan the screw placement on that, and then we waste the model that way. But we would not use screws for every patient just to save cost. It's expensive enough as is.
So you use mostly the CT scan. Is there a specific CT scan? Is it so for other centers that want to replicate this 3D modeling of spine,
Yeah.
is there a specific sequence of a CT scan that you guys use in your scanners, or is it just a regular CT scan?
That's an excellent question. So there's a couple things that need to be done, and that we struggle initially to get the radiology department to cooperate with us. They have to be 1 millimeter cut scans in the sagittal plane. The coronal plane doesn't really help because you want the striation of the layers to be with the model. Otherwise, it looks distorted. So you want cuts 1 millimeter going sagittally with the patient. That gives you an incredibly high resolution scan. And when they scan the patient, it has to be the entire segment of interest. They can do like a CT of the thoracic spine on itself and then the lumbar spine by itself. It has to be a conjoined study. They can bill for both, which we don't really care. It has to be an entire thoracolumbar spine together, because otherwise it's very hard to find the actual line with that distorted alignment and line them up, because then you're guessing. So if you really want to respect the curve of the patient, it has to be one chunk. It's not as important if you're doing for normally aligned patients. Very easy to put the models together, but if it's a bad scoliosis like these, you really have to have the whole thing done as once.
And how do you deal with the artifacts? So, you know, the post-operative, you have the CT scan, you have the screws in place, the instrumentation in place, but it seems like you've created models with that as well. Or is it just
Yeah.
the 3D iCAD, not the actual model that you do post-operatively?
So we had to have radiology do it with artifact reducing protocol. They have that. If they don't obtain that, it's impossible to reprint anything but the hardware post-op. So that first patient we did give the screws to, we just could not post-op print his model because they didn't do that. But if you window it correctly, metal is very high density. You can just print the metal. And that's why we end up printing the screws and give it to him as a thank you for doing this with us the first time. But now we've learned, and Radiology does it as an artifact reduction protocol, and it's doable. It's not as clean as without the screws, but it's definitely doable.
And have you thought about using MRIs to 3D print also, let's say, for not just for scoliosis correction, but actually for sometimes you get a simpler, lumbar adjacent segment disease. You have the artifact you can't see well on the MRI. Instead of doing a myelogram,
Hmm.
are you able to print the nerves to understand where the compression is or the cord
So
within the model?
we used a MR cysternogram to try that.
Hmm.
The results weren't as good because there's so many tissue layers in the MRI that you don't isolate what you're printing, so it's kind of mushy. We had some success with our basic science department here on pig models, and we're able to print 3D print brain or a skull with a tumor inside the skull. So it was a combined kind of CT MRI combo where radiology made that model for us. So they have to do the hard work. We just print it. It gets technically difficult. That's why it's much easier to do it for. Uh, I know Dr. Bendock was doing that or thinking about doing that for his aneurysm a while back because it's a TTA, so it's pretty much like bone in the vessel as far as density. You can just print that. But having soft tissue printed for now is a little difficult. Now they're 3D printing steaks and food and whatnot, so I'm sure it's doable. We just don't have access to that technology.
All right. How long does it take you to print these to create, let's say, from getting the CT scan to having the model on your desk? How long does it take?
So the 3D modeling I can do fairly quickly now, probably like 20 minutes. It doesn't take me as
Okay.
long as it used to. The first few times, you try to print, doesn't work, to do it again. But now that we've gotten familiar with it, it takes me probably 20 minutes, and I can send you the protocol if you'd like. I'm happy to share it with whoever just to save time. The 3D printing part, depending on your printer, and the better ones are more expensive. So you're talking probably 10 to 15,000 of a funded printer for it to save you 6 weeks of printing, probably 3 days. And that's with the
Okay.
good printer, and that's if nothing happens in the print. Because
So
one of the advantages of cutting the print in half is if one of the prints goes bad, you haven't done the whole thing and it's gone bad because that's really frustrating.
I see. I see. Okay. So now for obviously these are massive reconstructions. Patients are, in the ICU. And do you have specific pre-op and post-op protocols for patients? Like, do you have any cutoff, for example, for somebody for, a certain parameters, A1C or vitamin D or osteoporosis?
100%.
Do you have anything that you use for every patient's pre and post-op?
100%. So the reason why we're a scoliosis referral center is that for the past few years, we've come up with it was one of the few spine ERAS protocols, enhanced recovery after surgery, because, we tell these patients something bad is going to happen to you. If anyone tells you complication rate is low, less than 2 to 5%, that is the biggest lie ever. Something bad is going to happen. Our job is to make sure it's not something catastrophic, meaning it's maybe a small DVT, a small wound dehiscence there, maybe a pneumonia after surgery, maybe longer hospitalization care. We can take care of that. Or if it's something catastrophic, like a big screw pull out or a rod fracture, at least we have to know about it early so you don't linger with that catastrophic issue at hand. So everyone who comes in is part of that multidisciplinary program. So they see me, and then they see anesthesia before surgery. They see pain management before surgery. They see psychology because psychology, one, it rules out any kind of psychological behavior that's not going to make them thrive, and also makes them understand that this is a very, very long recovery. Meaning, I tell patients for the first 6 weeks, you will not like me. You will not be happy to see me in clinic. You're going to be miserable. You're going to blame me for all your woes. But at 6 weeks, you will be happier. Typically, HbA1c has to be less than 7.5. A lot of people look at the T scores and Z scores for osteoporosis. We don't. We look at pure bone density. So your bone density has to be above 0.7 grams per cubic centimeters at least. And if it's a long segment deformity, we ask for above 0.9 to make sure that they can withstand the stress to that edifice. Everyone gets calcium, vitamin D. Everyone gets a nutrition consults beforehand, and it's patient. So it takes about 6 weeks for them to see all of this. And if they're still there after that, and we have very frank discussions with them in clinic that, this is an investment for the rest of your life, but takes away things from you. Meaning, if you get a T4 to the pelvis, you can't wipe your butt normally, can't put your shoes normally, can't put your socks on. But if you're currently at the stage where you can't walk around with the grandkids, you definitely will be able to walk around, travel. But that's the extra we're giving you, and we're taking away a lot of limitations as far as day-to-day life. And we see enough of these patients that we're able to screen them appropriately now, and we've had some pretty significant success.
We have a question as well. Is there any difference in post-op handoff to patient for those who had 3D versus traditional?
No, everyone gets the same handout. Everyone at least see the 3D model, even if we don't 3D print it, so they get an idea of what's going on. But the way to keep our ERS certification for spine is that everyone gets the same pathway. My PA even comes in and gives them a course 2 weeks before surgery, reiterating everything. People forget you can't take ibuprofen and leave after spine fusion. So we say that again. Tell them you have to stop these medications, the blood thinners, the fish oil, all that before surgery. You can't do this and that, bending, twisting, golf. This is Texas, so people like to ride horses and all that, and they've done it after spine surgery. So we have to really emphasize on what they can and cannot do, and everyone gets the same treatment, regardless of whether it's 3D printed or not. 3D printed adds to that, so it makes them abide by it more, and it also helps us plan because we got very good at doing these. So a T4 to pelvis fusion takes us maybe 6 hours. If they're skinny, it takes us 4. Whereas before this program, these cases they're notorious for taking 16 hours, and 6 days of blood loss. We don't see any of that anymore. Our blood loss is capped at maybe 2,300, 2,200 was the highest number I've seen in the last 2 years. So it increases system efficiency, and it forces people to abide by a system, and that's when you take out a lot of the external variables.
Perfect. Well, I see there's a model behind you on your shelf, and
That's the first model we did. I left it as a souvenir. I didn't give that to the patient, just because I wanted to keep something in the office to remind me of it.
Well, this is fantastic. It has been a fantastic talk. Thank you for taking the
Thank you.
time. You've done something amazing by building something that complex and difficult and hard on the patients, and you made it into a streamlined process. This is makes me proud of being your friend and having been in the trenches with you down
Even though it's
so
the
many
dark
years
side,
ago.
but you'll come to the dark side soon enough.
Well, thank you, everyone. The EATS codes is in the chat if you want to take a CME for that. Thank you for joining us. Our next Grand Rounds will be in 2 weeks, same time. Thank you, everyone. Dr. Aoun, again, thank you so much for
Thank you very
for
much. You
being
guys
with
have
us
a good day.
today.